Okay, hi, my name is Jordan Moskoff. I'm from Cook County Hospital also, and we're going to do reversal of anticoagulation, specifically vitamin K antagonists and novel anticoagulants. We're going to be talking about a lot of different medications today. No one gives me any money. I do not get any of this, unfortunately. It's a very large pie. So let's just get started like we always do. This is a nice, normal day in the emergency department. You're having a great time, even have to get a chance to sit down and have a cup of coffee. And you see a stretcher roll by you. There's an old gentleman. He's got a bath towel wrapped around his head, completely soaked in blood. And there's a nervous-looking woman walking behind him. So you get up and you walk over and try to find out what happens. You look at the guy. His eyes are okay. He's moving all four. But when you ask him about allergies, he tells you he has a penicillin allergy about 4 different times, and that makes you think, well, maybe he's perseverating a little bit. You get his heart rate, it's between 40 and 50. His blood pressure is 280 over 160. I think you can all see where I'm going with this one. You talk to the daughter and say, hey, does he have, what happened? She said, well, he was an 82-year-old guy. He got up out of bed. He fell over, and he hit his head on the bedside table. And that's how he got that huge gash. Now, he falls down and hits the ground hard enough that she lives downstairs, and she heard the thunk. She comes running up, and she finds him in a puddle of blood. So does he have any medical problems? She's like, 2 months ago, he was in the hospital. He had a bad mitral valve. They put in a mechanical replacement for the valve, and he's on a blood thinner. Well, do you know what the blood thinner is? She reaches into the bag of medicines that she brought, and she pulls this out. Now, everyone in here just took a sigh of relief, right? We know this medicine. I've been using this medicine for 20 years. We know this. I can deal with this one. All right. But then she says, wait, he's not taking that one anymore. They had a lot of trouble controlling it. He didn't like getting his blood drawn, and actually he's on this medication. Now everyone just puckered up. So why is this an important talk? This is an important thing because this is one of those last 10 feet of track problems that we have. And what I mean by that is if someone goes over the track, there's not much you can do. It's 100 per minute, and you just kind of hope for the best. And if they're all the way back on the track, well, you have time. You can call a consultant. You can look something up. You can try one thing. If it doesn't work, you might be able to try something else. But sometimes we're in that last 10 feet of track, right before the patient's about to fall over. And if you kind of know ahead of time what you would do, what the medications are, how they work, when, if you don't have one, what would your second line be? Maybe you can separate good from great, and you might be able to pull that patient back from the cliff. So that's why I think this is good. This was good for me just to go through the literature, I got to be honest with you. So today we're going to talk about strategies for reversal, both for vitamin K antagonists, which is basically Coumadin, and the newer medications as well. But keep in mind while we're talking about this, reversal does not fix the underlying problem. And what I mean by that is this guy still has a hole in a vessel in his brain. Just because you make him, I won't call it procoagulant, but just because you reverse the anticoagulation, you don't fix that hole in his brain. So keep in mind, this is not a cure-all. And also, there's a reason the patients are anticoagulated to begin with. So as we discussed, are we going to reverse the anticoagulation? Keep in mind that there might be some problems with that as well. All right, so let's just get started first with Coumadin. It's a vitamin K antagonist. Anytime you have a lecture like this, unfortunately, we have to show the coagulation cascade. Something we use so infrequently in the ER that you didn't notice that this is the nitrogen cycle. And, whoop, sorry. And this is the coagulation cascade. I apologize. All right, so vitamin K antagonists hit these 4. 2, 7, 9, and 10. Do you have to remember that? No. But those are the 4 of the hits. It's all vitamin K dependent. So if we're going to replace this, if we're going to work with this, there's 2 things we have to do. One is we can give exogenous replacement, right? I can give some of the factors back. But the second thing is going to be endogenous regeneration, all right? We have to get the liver creating these factors again. All right, so we're going to talk about both arms of treatment here. So what happens if you have just a minor bleed? How do you want to check this? Well, first, get the INR. Up to 65% of our patients coming into the ER are not anticoagulated on their Coumadin. Believe it or not, it's a huge number, so maybe you get lucky. Roll the dice. Maybe they're not even anticoagulated and this isn't even necessary, all right? But then next move might be the whole Coumadin, but remember the half-life of Coumadin is 20 to 60 hours. That means if your INR is between 2 and 3, it can take up to 5 days before you get full reversal down below 1.5. All right, so that's not necessarily, if you don't have enough time, that's not necessarily what you're going to do. So that's when you might reach for your vitamin K. Vitamin K dose in a minor bleed is going to be 5 to 10 milligrams PO. You can expect this to start working in the literature, say, after 8 hours. I think 8, 10, 12 hours. It's all going to be about the patient's liver, okay? But this is how you get started. What if you have more of a moderate bleed? Now here I have a picture of someone's arm laceration, but I always think about, picture that patient who you've already packed their nose and they just keep oozing around it, or you have that patient with the laryngeal CA and their gums will not stop oozing. It's nothing you can really stop, but they won't stop bleeding. They're not going to bleed it to death immediately, but it's going to happen. So how would you do this patient? All right, well again, you check the INR and you can hold their Coumadin. Would you consider giving vitamin K PO to this one? Maybe. It depends how much time. But what else could we do? Well, can you give it sub-Q or IM? No. You don't want to ever give it sub-Q or IM. You get erratic absorption and you might get a hematoma at the site of the injection. So stay away from that. So now we're going to start moving towards vitamin K IV. Now most people hear this and the first thought they have is, what about anaphylactoid reactions? That's going to happen if you give it too fast. So the dose is going to be 5 to 10 milligrams IV, but no faster than 1 milligram per minute. Just 5 to 10 minutes. Nice slow push. Let your nurse know why. Say, hey, I'm worried you might get anaphylactoid. Make sure it's a nice slow push, and that's usually going to do it. And your not reversal, but your replacement of factors, the endogenous regeneration should start under 8 hours. That's the best I can give you, 6 to 8 hours, depending on the patient's liver. Well, what happens if this guy comes in? He either has a massive GI bleed or head trauma, or he's headed to emergency surgery, right? So what do we do with this guy? Again, check your initial INR. Maybe you'll get lucky, but this is a guy right away, you need to give him vitamin K, 5 to 10 milligrams IV. Don't hold back. You're not going to mess around with PO on him. And now we have to start talking about, replacement of factors. All right, so let's get into that. Now, replacement of factors is time dependent. The reason it's time dependent is actually the initial INR doesn't matter. When they look at morbidity or mortality on anticoagulated patients with significant intracranial hemorrhage, it's the 4-hour INR that is what you relate to morbidity or mortality. So there is time dependence here. We want to do quickly. So most of us would think, let me reach for fresh frozen plasma. Yes, sir?
Is that 4 hours after injury or 4 hours after initial vitamin K, or what's the...
Initial INR, repeat INR. Okay, so you have your initial and then a 4-hour repeat. So you reach for fresh frozen plasma. Well, what's the problem with this? Well, sorry. I'm hitting the button too hard. One is time. First, you got to get the patient ABORH. They got to go down. They got to thaw the frozen plasma, and then they're going to have to send it back up. And then remember that 10 mLs per kg is going to take an hour or so sometimes to put in. So your time is not your friend here. What about transfusion reactions? The same transfusion reactions you get with packed red cells, you're going to get with FFP. So whether it's TRIM, whether it's TRELI, whether it's TACO. Actually the biggest risk factor for getting TACO, and remember, that's transfusion-associated cardiac overload, CHF, from giving red cells, is not how fast you give the blood. It actually doesn't matter how fast you give the blood, but the biggest risk factor was getting FFP before you gave the blood. Patients who got FFP prior to giving the blood had a much higher risk of TACO. What about efficacy? Well, if you actually pull an INR off of a bag of FFP, the INR is about 1.6. Now, as Sean alluded to in the last lecture, when you look at the literature, you're either anticoagulated or not. 1.7 is considered anticoagulated, all right, in terms of your likelihood of bleeding. So INR is right at that edge. It's right at 1.6. It's not the greatest here, all right? You're just at the top. So there's got to be a better way, right? You have these 4 factors that need to be replaced. Might there be something that would just give you back the 4 factors? And of course there is. There's 4-factor PCC, also known as K-Centra. This specifically just has 2, 7, 9, and 10, okay? Most of the trade names you're going to know is K-Centra for this one. How does this work? Well, time is definitely your friend. This is a powder that you keep in your Pyxis, reconstitute at bedside, and inject over 5 to 10 minutes. So not hours, minutes. So that's huge. What about transfusion reactions? Well, there are none, because all you're giving is the factors. There's no proteins, there's no antibodies, so you're not going to have any transfusion reactions. This is incredibly safe. But does it work? Does it work? Well, fortunately, in the Lancet recently they did a nice head-to-head trial for patients who were emergently going to surgery who were anticoagulated. And what they did is they looked at vitamin K plus FFP versus vitamin K plus K-Centra, the 4-factor PCC, to see if they were going to be equivalent. Endpoints were hemostasis and INRs of less than 1.3. The K-Centra had a hemostasis of 90%, and FFP went to 75%. INR less than 5, K-Centra, the 4-factor PCC, had 55% versus a 10%. Stacked a little bit in their favor because the resting INR of FFP is 1.6. But the point is that 4-factor PCC is considered superior to FFP. What's the problem with it? Very expensive, right? So a lot of us are still going to be using FFP, but if it's not a cost issue and you have it, you should be using the Kcentra. Let's just go through some of the other options you have. What about 3-factor PCC? Well, it's missing the 7. Because it's missing the 7, it just doesn't work that well, and you really have to give it with something that has 7. Now, you can give it with IV vitamin K, you can give it with fresh frozen plasma, but eventually you're going to have to give some 7 if you're really going to reverse things. What about FEBA, or also known as active prothrombin complex concentrates? There's 2 names for this one, so it can be confusing. I'm just going to keep calling it FEBA. But this has 2, 9, 10, and activated 7. It works. You can use this, but because it activated 7, it's prothrombotic. So if you're going to compare 4-factor to FEBA, and you have the option, reach for 4-factor. If you only have FEBA, it's fine. It'll work, but you're a little bit more prothrombotic. This is also cheaper. Whoa. I'm not sure why it's doing that. I apologize. This is also cheaper than the Kcentra because it's been around for a long time in the treatment for hemophilia. All right. What about Novo 7? Novo 7 is just activated factor 7. This actually will make the INR go down faster than anything else. This will keep that INR low. But the problem is it doesn't actually work in terms of reversing the anticoagulation. They usually have to give multiple doses of Nova 7 if you're going to get it to work, or it has to be given with FFP. And there's rescues with, there's case reports. Sorry, I think the program is doing something. I apologize. There's case reports of having to give Kcentra to rescue it. So what you're basically looking at is 4-factor PCC plus vitamin K is your best option. FEVA is a good second option, and FFP is your third option. All right. So when this guy comes in, what are you going to do? You're going to check his INR. You're going to give him vitamin K IV, no faster than 1 milligram per minute to avoid the anaphylactoid reaction. Then you're going to start replacing his factors. If you have Kcentra, use that. FEBA is your second choice. FFP is your third choice. And then get your 4-hour INR to kind of get a sense of where you are. Okay? All right. Let's start talking about NOACs. I still like to call them NOACs. I don't like DOACs because to me it would be DOACs, direct-acting oral anticoagulants, so I'm just going to continue to call them NOACs. But these are the new drugs like Xarelto and Eliquis that we all know about. All right? So let me tell you a little story. I was working in the ER, and I get a call from a primary care friend of mine. And I'm sorry, I'm just going to do this because I know that's going to jump. I call a friend. He got a guy who's a musician who's on tour who got off an airplane. He's in his office right now. He's got tachycardia, a little bit of chest pain, and shortness of breath, and he's worried he has a PE. He's going to send him over to me so I can get the CT scan. If he's got a PE, he wants me to just give him a Xarelto because he's got a show that night, and then he'll see him in the office the next morning. So I know what you're all thinking. He was a musician. I'm not going to tell you. But what I'm thinking is that is crazy. How do you just give someone a Xarelto who has a PE and send them out the door? But that's kind of what we see. And the reason we see that is because of the efficacy. It works so well. Why do they work so well? It's a consistent bioavailability. You give a pill to someone, it doesn't matter their size, their gender, their age, any of that, their metabolism, it all works the same across all of your patients. So that's why it's so easy to give, and it's ubiquitous now. The onset is quick. You don't have to admit patients anymore to get their INRs therapeutic. You don't have to bridge them with enoxaparin any longer. The half-lives are shorter, and part of that is what makes them much more safe. The risk of a significant intracranial hemorrhage or a massive upper GI bleed on the NOACs is half of what it is on Coumadin. It's between 0.5 and 1.5% as opposed to 2 to 3%. Still low numbers, but this is much better considering how many patients are on these. All right, so they're wonderful drugs until you start bleeding. So let's just go over what we're going to do when they start bleeding. So again, we're back to our coagulation cascade. The thing to remember about your NOACs is there's 2 flavors. There's 2 kinds of NOACs. So you need to know which NOAC you're dealing with to get started off. The first kind is your direct antithrombin inhibitor. Okay, the next kind is going to work here at your factor 10A. Each kind only works at one area. So you need to know which one you're dealing with because the treatments are going to be different. So let's get started with your direct antithrombin. That's your Pradaxa, dabigatran. It works over here, okay, just at the one spot. So just to go through a little bit of housekeeping on this. Your peak concentration is going to be 2 to 3 hours after taking the medication, so it starts to work right away. Half-life is 9 to 17 hours. That's a big difference between 20 and 60 hours that we had on Coumadin. And it's mostly processed in the kidney. That's going to be important. So when you have a minor bleed and someone's on Pradaxa or dabigatran, what do? Well, you can start with local hemostatic measures. Maybe you're going to get lucky and get the bleeding to stop. And then, as long as that works, just hold 1 to 2 doses. That's all you have to do. The half-life is so short, the vast majority of patients who come in with bleeding get the bleeding to stop however you need to, just hold a couple doses, and they do fine. You don't have to do anything larger in terms of intervention. But what happens when this guy comes in with the massive upper GI bleed or the significant intracranial hemorrhage? Well, you start with charcoal, and that's because it's a lot of GI absorption. So especially if it's an intentional overdose, give them charcoal, try to absorb it away, and you can get rid of it. Next, because you have all that renal clearance, you can do hemodialysis. In a 4-hour hemodialysis run, you'll get about 70% of your dabigatran gone. So this is an option here. What about 4-factor PCC or FFP? Can you use that from here? No. You can't because it's the wrong part of the pathway. You're not replacing anything that's missing, so it's not going to help you. What about FEBA or vitamins or activated 7? Well, actually, these can work. They work at different parts and it's different part of the coagulation cascade. There was a nice study that was being done where they were giving patients with significant intracranial hemorrhages these drugs to see if it was going to help reverse their anticoagulation, and they stopped it early. The reason they stopped it early is this drug came out. This is the antidote to Pradaxa. I'm not going to try to pronounce this, but it's called, there we go, I'm sorry, called Praxbind. That's easier, right? So this is an antibody to Pradaxa. It's basically just going to bind it up immediately and grab it out, and it doesn't cause any extra thrombosis. Just takes the Pradaxa out. It's a wonderful drug, but the problem is it's incredibly expensive. The wholesale is $3,500, meaning that's what they're selling it to your pharmacy for. At my institution, it costs our patients $20,000 per dose. This is life-saving. We have no choice. We have to use it for $20,000 a dose. So let's talk about the factor 10A because the computer wants me to. So factor 10A is a way to remember these. Like, how do I know which one is? And if you remember nothing else from this lecture, and I'm sure you won't, is factor 10A, all the generic names have an XA in it. All right, so that'll help you remember that this group, this is the other flavor of NOAC, okay? This works here, right in the center of your coagulation cascade, all right? Just to put them all together, because it's just easier that way, your peak is in 2 to 4 hours. Half-lives are about 12 hours each. They're going to be liver and kidney, a little bit heavier on the liver, and they're highly protein-bound. That is how they're different than dabigatran, okay? So your minor bleed comes in, it's the same drill. Local hemostatic measures, maybe you get lucky, and then because the half-life is only 12 hours, hold 1 to 2 doses. That's all you have to do. Have them follow up with your primary care doc in the morning or admit them for whatever else is wrong with them. All right, you really don't have to do much. It goes out of the system pretty quick. This is not Coumadin, and that's nice. But what happens when this guy comes in? All right, so we're going to start again with charcoal. Especially Xarelto has a lot of GI absorption. So if they just took the Xarelto or it was a, or if it was an intentional overdose, then you want to make sure you get the charcoal in them, okay? What about 4-factor PCC, or I have FFP smaller now because I can tell by the time in this lecture, FFP is going away, right? So would Kcentra work? Well, it would work, and that's because this is a 10 antagonist, and in Kcentra, you have 2, 7, 9, and 10. It's not going to work great. You're talking 80%, but it can work. What about FEBA, your activated prothrombin complex? Yes, because again, you have 10 in it. This is more prothrombotic because again, you have the activated 7. If you have to choose between the two, your first choice is going to be your Kcentra, your second choice is going to be your FEBA. If you just have FEBA, use FEBA. There's nothing wrong with that, okay? What about recombinant factor 7A, or active 7A? Will this work? No, this doesn't work. You're at the wrong part of your coagulation cascade. We're not really using it for anybody anyway, but if you're really throwing the kitchen sink at someone, you can do it. You're probably not, it might be prothrombotic, but it's not great. What about hemodialysis? Not in this one. It's highly protein bound. You cannot dialyze away the factor 10As. It's only for Pradaxa. I'm sorry, it just keeps doing that. So then, are there any antidotes? Not yet, but there's a couple coming. So the first one is called Adenexate alpha. All right, it's in clinical trials right now. It may be released as soon as this spring. It's pretty neat. What they did is they made a fake factor 10, and so the Xarelto and all will bind that one instead. The problems they're finding with it is that it's a bolus followed by an infusion, and it seems to be difficult to maintain. And also, it's procoagulant, so you might end up giving more clots to your patients. This one is crazy. This one supposedly is going to be an antidote to every antithrombotic there is. But it's maybe way too procoagulant. Just picture patients turning to jelly if we give this stuff, so I don't know if this is going to be an option or not. It's in testing now. I don't know how far this one's going to get. But we may soon have an antidote to Xarelto as well, but we know that that also is going to cost a ridiculous amount of money. So just to go back through it, if you have a minor bleed, doesn't matter what kind of NOAC or DOAC you have, you're going to do local hemostatic measures, hold for 1 to 2 doses, and they should do fine. But when this comes in, you have to know first, is it direct antithrombin or is it a factor 10A? Okay? If it's a direct antithrombin, give them the antidote if you have it. That's your first. If you have the antidote, give it. Okay? Otherwise, you're going to use charcoal, dialysis, APCC, and factor 7A. All right? If you have the factor 10A inhibitors, remember you can find that using the generic name, then you're going to use charcoal. You're going to focus more on their factor 4 PCC, because remember you're replacing that 10, and then we're going to wait to see if there's an antidote. Of course, if you don't have any of these things, FFP, throw it at them, throw anything you have at the patients and see how they do. Okay? All right. Now, when going through this, the first thing I noticed is this all costs a lot of money. So what I'm about to say, this is not representative of the institution I work at or this conference, but I have started a change.org petition to not let the FDA price gouge our patients. If you have no choice but to use a $20,000 drug, you're going to have to use it. And if every ER has to, if every ER has to stock multiple doses of 3 different antidotes, that's money we can't spend on our patients for other things. So if you have a chance, please visit change.org. Thank you. Any questions?